It's 12 o'clock, so I think I'll get started. Hank Paulson here. I'm going to introduce myself. I am been a professor at the university for 17 years. I did my MD PhD at Yale, did my neurology training at Penn. Most of the residents will not know this, but I trained in movement disorders and neurogenetics, and then I moved to Iowa for 10 years, where I ran a Huntington's Disease Center of Excellence and saw patients with Parkinson's disease and other movement disorders. Was privileged to be able to move to Michigan 17 years ago, and very quickly got roped into doing something I had never done before, which was seeing patients with cognitive disorders. And so now I spend my clinical time seeing patients with cognitive disorders, although the laboratory still does work, broadly speaking, in neurodegenerative diseases. I really have no relevant disclosures today to companies or things of that sort. And I will say that I have grants from several groups. I'm on the advisory council for NINDS, and I just recently joined the scientific advisory board for the Van Andel Research Institute. When I go to the Alzheimer's Center, which is on the north side of campus, I see this picture every time I go in, and I love looking at it. It was actually painted by someone who had cognitive impairment. I think it's a beautiful painting, and I think it illustrates something very important about, oh, by the way, here's where the center can be found, here we are right here on main campus. The Alzheimer's Center is up here on Commonwealth Boulevard, and not far from the East Ann Arbor clinics. So I think what it tells me, it reminds me, and one of the things I feel good about seeing patients with slowly progressive degenerative diseases is that it happens to people over time. They still are those very same people. I love art, and Willem de Kooning is one of my favorite artists. You might recognize his work from the angry women paintings. He also has some beautiful abstract paintings that he's done. This one here on the right was made very late in life when he had dementia. I don't like it as much, but it's still a beautiful painting. And I think the reality is, again, he, like many people, as he aged and had dementia, he was still that person. And I think it's an incredible privilege to work with individuals over time who may have lost some elements of memory or executive function and even behavioral changes, but they're still very much that same person. I thought today would be a good chance for me to give an overview, not only about updates in Alzheimer's, but also about the Alzheimer's Disease Research Center. Louis Morgenstern had a beautiful talk a couple months ago, giving us updates on basic and other programs in the cardiovascular group, of the cerebrovascular group. And I thought the same thing could happen here with the ADRC. But first, I'm going to go through some updates in Alzheimer's. Let's start with a little bit of background. I think everyone here probably knows this, but I think it's important still to remember that we're all on the same page. Alois Alzheimer described in 1907 the case of Auguste D. And he described in front of an esteemed panel in Germany. He talked about this woman who developed dementia. When objects are shown to her, she does not remember after a short time which objects have been shown. Asked to write her name, she forgets it. She seems not to understand what she reads. She had a progressive dementia. He had looked at her brain. He saw these plaques and these tangles. He described this case. At the time, it was thought to be atypical, pre-senile dementia. Didn't tell us much about a garden variety late onset dementia. We now know what he described then, in fact, are the hallmark features of Alzheimer's disease. And this cartoon on the left is completely inaccurate. You know that if you take a slice of a brain, it's just chock full of processes of neurons and non-neuronal cells. But for the purposes of making it clear to individuals, if these are normal purple neurons with a neural pill that's clean, in Alzheimer's disease, of course, they're amyloid plaques, which have beta amyloid, and they're tangles within inside the neuron. Shown here as these squiggly purple lines. This is an image over here where you can see the ghosts with the neurofibrillary tangles from neurons, and you can see the neuritic plaque down here. Beta amyloid is in the plaques, and tau is within those tangles. So the two key proteins, beta amyloid and tau, underlie plaques and tangles respectively. Now, if you think about Alzheimer's disease, this is a crude schematic of what happens. Some cause, it could be gene defect, it could be environmental exposures, it could be age, a lot of different things that can play a role, can lead to the accumulation of the A-beta peptide. The A-beta peptide does form plaques. This itself probably causes some neuronal injury and probably causes other things to occur in the brain. There's no question that this generates an aberrant behavior of tau within neurons. Tau forms fibrillary structures within neurons. That is a toxic element in the cells. It definitely damages neurons in a very big way, leading to circuit damage, dysfunction, and death of neurons, and dementia. So amyloid clearly is an initiator of a process. It's not sufficient for disease, but it's an initiator. And it's really an A-beta driven tauopathy that what is Alzheimer's disease. You have to have both proteins, and A-beta comes first and tau occurs downstream. What's very clear now, it wasn't so clear 10 years ago, is the contribution of cells other than neurons. And in particular, I think that microglia and astrocytes play a very important role in Alzheimer's disease pathogenesis. And the other thing to remember is that the process occurs over decades. This is not a very acute or a subacute process. It takes a long time. And so here's an illustration of that. We have shown here is a amyloid PET imaging of a cognitively unimpaired individual. And you can see there's no amyloid based on the blue staining. Here's an individual with Alzheimer's disease, lots of amyloid in the brain. This is an individual who is cognitively unimpaired as well, but has lots of amyloid in the brain. If you actually look at many individuals, this comes from the Healthy Aging Brain Study, and you look at the level of amyloid in the brain on the y-axis, these are cognitively normal individuals. Many individuals do not have a lot of amyloid, some do. If you look at those with mild cognitive impairment or MCI, you can see that they're really parceled into two groups. And the pink would be those that have amyloid deposition. Those would be individuals who would probably go on in almost all cases to develop Alzheimer's dementia. And individuals highlighted by this green would be individuals who do not have amyloid in their brain. Their cause of their MCI is something other than an Alzheimer's disease process. And even if you look at in these individuals who were actually clinically described as Alzheimer's dementia, you can see that there are two individuals who really certainly cannot have Alzheimer's disease by the definition of having amyloid deposition. So again, this is a slowly progressive process over many years. There's a long period of time when individuals are asymptomatic. There's a period of time where people have mild cognitive impairment or MCI, and then there are stages of the dementia itself. Recently, the new revised criteria published by Clifford Jack and others in the Journal of Alzheimer's Disease and Dementia talked about 6 stages of Alzheimer's biological processes. Stage 1 would be individuals, stage 0 would be individuals who have a determinative gene, let's say a dominant acting mutation in presenilin, but don't have any signs of disease. Stage 1 would be those individuals who have no symptoms whatsoever, but have some of the biomarkers, amyloid changes, beta amyloid, tau changes. And of course, when you've reached the stage of actually having symptoms, it's MCI, and then of course, mild, moderate, and severe dementia itself. These are clinical stages here. So to the key points today, anti-amyloid therapies. This is a figure from a paper that Judy Heidebrink and I wrote about 1.5 years ago. It really was talking about the failures of the field to approve aducanumab as a therapy for Alzheimer's disease. You remember that amyloid, beta amyloid is produced by a cleavage event in the amyloid precursor protein that generates beta amyloid, which can form oligomers and fibrils and ultimately plaques in the brain. These are various antibodies, donanemab, aducanumab, lecanemab, solanezumab, gantenerumab, that are all antibodies against different types of amyloid, showing where they are along the pathway. Aducanumab is dead in the water. It was actually approved. It should not have been approved. It's no longer available. It really was ineffective. Solanezumab and gantenerumab really have not shown efficacy in terms of any kind of clinical benefit whatsoever. And so I think they're also probably dead in the water. Lecanemab and donanemab have been approved by the FDA for use in Alzheimer's disease. So this is a figure from one of the earlier papers with lecanemab, where they showing you in the figure on the right is the change in amyloid in the brain with different doses of the lecanemab antibody. And over time, over 18 months, you can see that 10 milligrams per kilogram actually led to a really marked elimination of amyloid in the brain. So that drug, lecanemab, does a phenomenal job of getting rid of amyloid in the brain. This is actually the data from the phase 3 study, which did use 10 milligrams per kilogram. And again, you can see that there is a really outstanding reduction in the amount of amyloid in brain. So basically, you've taken these people who had lots of amyloid, and their brains are almost cleared of amyloid at the end 18-month time point. This is actually the phase 3 study, and this is the key primary endpoint, which was looking at changes in basically an Alzheimer's rating scale. And you can see here, I have a little trouble giving this. This is individuals at placebo. You do see a change over time in their Alzheimer's disease rating scale sum of boxes. And you can see that there is a statistically significant slowing of the rate of decline. It's not anything like the clearance of amyloid, but it is increasing over time over the 18-month time point. Now, when I talk to patients about this now, I got FDA approval last year. We don't really know how it's going to work in the real world scenario. It's still early days. When I see people in the clinic now, they're coming in and they're saying, I want the anti-amyloid therapy. And so I need to talk to them about what it is. And I draw them using my arm, a course of disease where there's a change over time. And then I describe what would be the ideal therapy, would be something that I would give at that flexure point and the green arrow going back up that completely recovers the symptoms of the individual. That's a fantasy drug. We'll never have that. And then I describe what I would be happy with, which would be a drug that completely stopped the disease in its tracks so that the degree of cognitive impairment didn't change over time. But what the reality is for our patients is that there is a modest, statistically significant slowing of the rate of disease progression in the population. And I tell the patients, I will never know if it's actually benefiting you because I can't do a case control with you. You are the only person I'm giving the drug to. And so that is one of the things that they need to understand when you think about this medication. Donanemab got approved this summer. It's a very similar type of antibody. I'm not going to go through the details of it. Same kinds of studies showed a clearance of amyloid from the brain. They did a probably better job of looking at the loss of amyloid over time using amyloid PET imaging. And they did a good job, I think, of looking at how tau changes in response to the amyloid therapies. And I think what you can say from this particular study is that it's similar to lecanemab in the benefit that occurs, same kind of slowing of rate of progression, same kind of marked reduction in the level of amyloid in the brain. And what they also showed is that those individuals who don't have a lot of tau already in their brain, a lot of tau deposition, do a little better in response to the medication. There are a couple papers here that you could do to read about some of the biomarkers if you'd like to. So despite the similarities, there are some differences. One targets soluble aggregated beta amyloid, that's lecanemab. One hits plaques, that's donanemab. Infusions every 2 weeks for lecanemab and every 4 weeks for donanemab. The rates of a major side effect, which is an amyloid, sort of amyloid therapy imaging abnormalities, which are essentially edema in the brain, sometimes with hemorrhages, is slightly higher in donanemab than it is in lecanemab, but it's high in both, and that's a very important risk factor to talk about. Dosing is scaled to weight for lecanemab, 10 mg per kg, and that's versus a fixed dose for donanemab. We don't really know how long the treatment would be for lecanemab. We have a pretty clear idea that with donanemab, you would stop the medication after a year. I think the reality is with lecanemab, we're not going to continue the medication much longer. So it's not on the formula yet here. Lecanemab is, and we have patients who are taking the medication. While we await the real world outcomes of the anti-amyloid therapies, I think it's already changed the game in our practice. 2 years ago, people would come in, we would evaluate them. We'd say, yeah, there's something going on. Let's get neuropsych testing. Let's do imaging. Let's wait a while. We'll see you in 6 months. They come in now and they say, I want to know, do I have Alzheimer's disease? I want to know now because I want to take the therapy. And we're seeing that a lot. And so I think we're moving more quickly towards a diagnostic evaluation of individuals. My couple thoughts on this, it's only for those who have biomarker proven mild Alzheimer's disease. Okay, you have to have an amyloid PET, you have to have CSF evaluation of the markers. It's not a home run therapy by any stretch, it's a single at best, okay, and that's important. So it's important to really counter the unrealistic expectations. I think people come in and they say, there's a cure for Alzheimer's. It's not a cure for Alzheimer's, and we need to make sure they are aware of that. It's likely most effective if given early in the course of disease. I think the guideline modifications might change as we get more real world data. And coverage varies. Medicare covers. Michigan Blue Cross Blue Shield does not cover lecanemab. Okay, they don't feel there's a significant evidence of efficacy at this point in time. I think now, though, is an important opportunity for all of us when we talk to our patients, and in fact, for everyone we know, that there are many factors that modify dementia risk. And so when patients come in and they want to know about the anti-amyloid therapies, we need to talk about those things. And so if there's one really important slide in this talk, it's this one, because I want you all to go and look at the Lancet Commission from this summer, which talks about modifiable risk factors in Alzheimer's disease. And what's shown here on the left are 14 different modifiable risk factors from early life, which would be level of education, to late life, social isolation, air pollution, and visual loss. And in midlife, hearing loss, high LDL, various things you can read about here, smoking, hypertension. These are all modifiable risk factors you deal with. One thing that's not shown here is sleep. It doesn't meet their criteria, but I think actually restful, full sleep and treatment for obstructive sleep apnea are very important when you think about cognitive impairment. But aerobic exercise and the various things here are very important. And this is another figure from the same commission. Again, I encourage you to look at. They talk about modifications that one can do with respect to these various modifiable risk factors and how they might actually act in our brain and our body to slow the dementia risk. So again, I encourage you to take a look at that. With that background and what I said, the game is changing in terms of what patients want. Let's talk about precision diagnosis with biomarkers. This is a figure a couple years old now from David Holtzman and colleagues that shows you various biological processes as the function of disease. And again, Alzheimer's disease is occurring over a 30-year period roughly. There's a long period preclinical, asymptomatic. One of the first things you see is amyloid accumulation. You can see microglial and astrocytic activation that occurs fairly early. Tau deposition really comes later. And what I'm showing you on this particular, oops, let's go back. And then synaptic dysfunction occurs later. And really clinical symptoms don't come until way down here. With that sort of backdrop of the biological processes that are going on, let's look at the biomarkers that occur. And this is again from Clifford Jack's recently revised criteria for diagnosis and staging of Alzheimer's disease. It's worth looking at. And again, here you've got amyloid abnormalities that accumulate quite early in the course of the disease. Mesial temporal tau accumulation occurs later. You don't really see neocortical tau till up here, and you don't really see neurodegenerative features more broadly in clinical staging till here. So if I were to map out in gray the area where there's symptomatic changes that occur, it's pretty far out here. So these other things are occurring well before their symptoms. There are many studies that have looked at these biomarkers as a function of time in preclinical and symptomatic AD. I'm highlighting this one, which came out in New England Journal this past year, because it's from a Chinese population that's different than what we typically see in the literature. This was the China Cognition and Aging Study. There were many thousands of individuals. They did a nested case control. They took about 650 participants who developed AD and an equal number of age-matched participants who did not. And then they looked over time with these various indices that they had. And as you can see on the panel on the right, there are several things that occur. The A beta 42 abnormality can be seen up to 15 to 17 years before Alzheimer's. A phosphorylated tau form, p-tau 181, is shown again later. And of course, the changes in the clinical dementia rating scale, sum of boxes, occurs quite late in the course. This here is hippocampal volume. That occurs fairly late in the course of the disease too. So we have these biomarkers that can actually capture signs of the disease before their symptoms or early in the course of symptoms. And if you think about the Alzheimer's field right now, we've heard about Alzheimer's as A and tau as, amyloid A and tau as key core biomarkers, also neurodegeneration or N, so ATN, these standard criteria. In addition, inflammation, vascular changes, and alpha-synuclein deposition. These are all relevant things when you think about Alzheimer's disease and related dementias. I think right now, the ones we're using increasingly clinically, we didn't use amyloid PET much clinically like 2 years ago, but I think we're now using it a fair amount. Amyloid PET, you can use p-tau from the blood, and p-tau 217 is a little better than p-tau 181. That actually is fairly sensitive and specific for signs of tauopathy and amyloidopathy. And of course, MRI can be very useful not only for the evidence of neurodegeneration, but also for vascular changes that occur. It's not to say we don't use FDG PET or other things, or we couldn't look at GFAP. I think eventually, once you actually have a good peripheral blood assessment of the seeding amplification assays for alpha-synuclein, that will become part of the repertoire that we can use as well. So we, again, that has kind of changed the way we do business. Now, in terms of our Alzheimer's Center, plaques and tangles are important, but there's so many other things that are relevant to the disease process. And so I want to talk a little bit about that. In order to talk about that, though, you first need to remember that Alzheimer's disease can occur early, in which case, let's say before age 65, in which case, not uncommonly, is highly genetic. It can be in families with dominantly inherited mutations in the amyloid precursor protein gene, APP, or in the two different presenilins, 1 and 2. Of course, individuals with Down syndrome who have 3 copies of chromosome 21, have a triplication of APP, and therefore they will develop amyloid deposition in Alzheimer's as they get into their late 30s and 40s. Late onset Alzheimer's disease is a different kettle of fish. It's the bulk by far of Alzheimer's disease. There are genetic components to it, and apolipoprotein E, or ApoE, is by far the biggest genetic factor, particularly in those of European descent. There are other smaller genetic risk factors, and that's what I'm going to highlight here, because that brings us beyond the amyloid. Again, the amyloid precursor protein is cleaved to generate beta amyloid. It is not at all surprising then that mutations in APP or mutations in presenilins can actually drive the process of Alzheimer's disease. There's no question that the changes in the accumulation of beta amyloid by these mutations is a driver of disease and in families who have dominantly inherited disorders. Now, if you look at all the genetic risk factors in Alzheimer's disease, one just jumps out, and it's ApoE. It's a hugely important genetic risk factor, not itself sufficient to cause disease. It's not a dominantly inherited mutation. It's a major risk factor, and it drives people toward getting Alzheimer's disease, although it is not itself sufficient. Genome-wide association studies and other studies that are coming out now have identified many, many different other smaller genetic risk factors. This is by far not all of the factors that have been identified. There are over 50 now. And I'm not going to go through these, don't worry. I'm not going to go through the details. I just will point out a few things. Let me just point out TREM2. We don't get a chance to talk about TREM2, but TREM2 is actually a significant risk factor. And it's really in microglia and not in neurons. So it's already telling you that you got to get away from amyloid a little bit when you think about the disease process. So here are a couple of those factors. And what we're looking at is we're mapping the odds ratio of disease. The red lines to the right are increasing your odds ratio. The green lines to the left are decreasing your odds ratio. This is the minor variant in these various genes. And so you can see that the ones over here, the minor alleles, decrease by about 10% your risk of Alzheimer's. The ones over here increase your risk by about 10%, so odds ratio of 1.1. If you were to map ApoE4 on this map, it would be in the next room. It's not 1.1, it's not 1.5, it's 3.7. So it's massively big, a genetic risk factor. And again, I emphasize, particularly for those of European descent, the allele frequency, of course, ApoE3, which is neutral, is very common across populations. The amount of ApoE4, which is the disease-conferring risk allele, varies among groups. In white Americans, it's 0.14, and in Black Americans, it's 0.26. I want to emphasize that the extent to which the ApoE4 drives disease varies in Black Americans depending upon the kinds of local African ancestry their genome has. So it's not very straightforward. For those of European descent, it's pretty easy to say it's the 3.7 odds ratio increase. Highest ApoE frequency is in New Guineans, it's 0.37, so 40% of the alleles there are ApoE4. So what is ApoE and what does it do? I'm highlighting this here because I want to point out that it's abundantly expressed in astrocytes and microglia. It's heavily involved in lipid metabolism. It's part of these lipid particles. So really, you've got to be thinking about things beyond amyloid. Yes, it does bind A beta, and the various E2, E3, and E4 vary in the extent to which they bind A beta. But really, I think ApoE does a lot more than just influence the levels of A beta. So if we go back to these genetic risk factors now and you say, what are they associated with? Well, several of them are associated with synaptic function or endocytosis. Many of them are associated with lipid or cholesterol metabolism, and even more, many more are associated with immune system and neuroinflammation. And if you actually look at the expression patterns of these genes, many of them, way beyond the number here, are expressed particularly in immune cells. And what I'm telling you is that the immune system is critically important for Alzheimer's disease. We haven't fully figured that out. I think the ability for it to be a target for therapy is a very exciting area in the field. Okay, final point I want to talk about updates in Alzheimer's is heterogeneity and multiproteinopathy. We think about Alzheimer's as a fairly simple disease, but when you think about dementia, it is not at all simple, okay? Dementia is incredibly complex and varied in the population out there. And so many studies have failed in identifying therapies for Alzheimer's disease, I think in part because, one, they didn't know how to really evaluate and show that it was Alzheimer's disease. They had a mixed bag. But the other thing is, even if you were able to show with biomarkers that they have Alzheimer's disease, very often there are other things going on as well. So there's really a multiproteinopathy that occurs. So we're in Michigan, so we love cherry pie. The best cherry pie is not that gelatinous thing. When you cut it, it doesn't ooze. You want a cherry pie that oozes all over the place. This is what people show you, what the frequency of dementia, that it's Alzheimer's versus vascular versus Lewy body versus FTD. Notice how clean cut the pie pieces are. That's not how it is. It's an oozy, runny pie. And in fact, the overlap is the rule among the dementias rather than separation. So this is quite an old thing from Jim Leverance. It's almost a decade old, and it's mapping out that pie. And here in blue are individuals with Alzheimer's. Only 14% had pure Alzheimer's in a pathological assessment. 22% had AD plus Lewy body. 12% had AD plus vascular, and 13%, as many as had pure AD, had AD, Lewy body, and vascular. And you can see Lewy body likewise had vascular. FTDs mixed up. This yellow here is all hippocampal sclerosis. We'll come back to that, because now when we think about hippocampal sclerosis, we're thinking about a different syndrome than we used to think about. So if we go back to that Clifford-Jack biomarker assessment over time, you saw this earlier, and these are the biomarkers, and again, these is where the clinical signs of disease are. And you imagine an individual who not only has Alzheimer's, but has Lewy body, or has vascular, or has TDP-43 proteinopathy. You're going to see a shift in these neurodegenerative and clinical stagings to earlier in the course. And that's probably what we see. We're often struck when we see someone in the clinic who we diagnose them, and their rate of progression is much more rapid than we expected or slower than we expected. And it could be that's in part due to coexisting pathologies that we haven't yet mapped out. So if you think about the neurodegenerative dementias, there are 4 key proteins to remember. They're A beta and tau. And of course, A beta is not important only for Alzheimer's, but for amyloid angiopathy. Tau, Alzheimer's, a subset of FTD, progressive supranuclear palsy, and chronic traumatic encephalopathy. Alpha-synuclein in Parkinson's disease and Lewy body dementia, as well as in multiple system atrophy. And TDP-43, hardly knew about TDP-43 15 years ago, but it's become very important. It's involved in most FTD, most ALS. It's also involved in a condition I'll describe called LATE or LANS, and also probably involved in CTE. There's the 4 horsemen of the apocalypse. If you're a historian of football, there's the 4 horsemen of Notre Dame. That's a long time ago. I like to think of the 4 horsemen of dementia, which are TDP-3, alpha-synuclein, beta amyloid, and tau. And those are, again, the diseases they're associated with. You know a lot about AD. You know a lot about Lewy body and Parkinson's disease. Just to highlight quickly, CTE, chronic traumatic encephalopathy. You can see tau deposition in the sulci that occur in individuals who had repetitive concussive injuries. CTE is not just a tauopathy, but that's a very important part of it. And then limbic predominant age-related TDP-43 encephalopathy with neuropathological changes, late NC, is associated with accumulation of TDP-43, which you can see here in the hippocampus in some subset of cells. In Alzheimer's disease, we know that it's an age-dependent disorder, but the reality is if you make it to 95, you're not probably going to get Alzheimer's. And if you look at the neuropathological changes in an autopsy series, these are looking for Alzheimer's disease neuropathological changes, severe. It increases over time, but at some point it kind of backs off a little bit. This is not the case with the TDP-43 pathology that occurs in late NC. And what's showing you here, particularly a severe TDP-43 staging, that increases, so not much at all at 73, increases over time. So individuals in 90s, 95, 100 have a lot more TDP-43 accumulation in the hippocampus. And this is a recent paper. It's worth looking at. It's from Corvo Lecavalier and a group of other scientists, mostly at the Mayo. And they're looking at this late NC syndrome and limbic predominant amnestic neurodegenerative syndrome. I think people don't like the term encephalopathy when we talk about late, because these individuals don't have an encephalopathy. They often have memory issues that are slowly progressive, but I wouldn't call it an encephalopathy. So I think LANS is a way to get away from that and think about a clinical syndrome that involves memory issues late in life, particularly in the limbic system. And if you just look here, they've taken individuals. So this was a study where they actually looked at individuals who actually had autopsies. They had clinical data on them. And they went back and sort of developed a sort of a set of criteria by which you could identify someone with a limbic predominant amnestic neurodegenerative syndrome. And when you look at those individuals who have the highest likelihood of having sort of the limbic predominant amnestic syndrome and not Alzheimer's disease, and you do FDG PET imaging for hypometabolism in the brain, what you see is medial temporal lobe, maybe a little inferior frontal, quite different from those individuals who have a low probability of this syndrome, but more likely to have Alzheimer's, where their hypometabolism is more lateral temporal and parietal and a little more broadly frontal. Okay, that is one illustration. And if you actually measure these over time, where you've actually identified those retrospectively who are likely to have who have what a high probability limbic amnestic neurodegenerative syndrome, their rate of progression over time, looking at dementia rating scale, sum of boxes, is very slow. These are individuals with a high probability of that. These are ones with a more intermediate probability. And these are individuals who have more of a low probability, more like an Alzheimer's etiology. So what you can take home from this study is if you see someone who is 70, who has a dysexecutive memory syndrome, it's probably not going to be LANS or late. But if you see someone who's 85 and has pretty much a pure memory issue, not much of an executive problem, and slowly progressive, and their MRI just shows some medial temporal atrophy, it's probably not going to be Alzheimer's. It's probably going to be LANS or late. We don't yet have the biomarkers for the TDP-43. It's getting close, but we're not there yet. And I think the reality is in a couple of years, with people who are in their 60s to 90, we'll have alpha-synuclein, TDP-43, amyloid, beta amyloid, and tau markers that we can look at. I'm going to ignore that. So with that update on Alzheimer's, any questions about what I said so far? Eva.
Are there any risk factors that can be predetermined as to who will get ARIA?
Thank you. For the audience who's on Zoom, what Dr. Feldman's asking is, are there any risk factors we can identify those who are more likely to get ARIA or not? The overwhelming risk factor is ApoE allele status. And so I think this has changed the game too. We used to not get ApoE allele status, but now when someone's thinking about doing an anti-amyloid therapy, we will get the ApoE status. If someone is homozygous for E4, the risk of developing ARIA and a hemorrhage is much greater, okay? If someone has microhemorrhages on their scan, they really shouldn't be taking an anti-amyloid. I saw someone in clinic last week, came in charging to take anti-amyloid, had a positive amyloid scan, had an MRI which was read as completely free of any hemorrhages. But when I looked at the susceptibly weighted images, I could see 6 little microhemorrhages. And I told them I am not comfortable starting on this medication. In fact, they were on a baby aspirin. I said, you probably don't need that. So maybe we come off this. So again, a few microhemorrhages I would consider a biomarker risk factor. If you have 4 or more, you should not take this. That's an exclusionary criterion. And if you have ApoE4 homozygosity, you probably shouldn't take it. that risk factor is also telling us probably something about the biological mechanism of action. These amyloids are getting in the brain and sucking things out. They're probably going through not just the sort of the CSF, but actually going through the vessels. And probably if someone is already predisposed with an amyloid angiopathy, have friable vessels, there's a problem with that. Did you have a question, Catherine?
CDR score from baseline. So as a clinician, what do these clinical features look like to you? Like when you see those people who are getting better?
Yeah, so the question is, when people get better on their scores, very often when people get better on their scores, it's because they or we or somebody has initiated a change. Let's go back to those modifiable risk factors. If someone is socially isolated and now they're no longer socially isolated, they are going to do better. If someone has sleep deprivation and is sleeping better, they're going to do better. If someone has not been eating well, they're going to do better. If they weren't exercising and now they're exercising, they're going to do better. So I think we can see improvement in scores. And I think for those individuals who have the Land syndrome, what we should really be focusing on is not any kind of a therapy other than those modifiable risk factors. Let's move ahead. Yeah, go ahead, Stephanie.
I was just wondering the multi-proteinopathies, how do those proteins, or do they kind of co-localize? Are they?
Yeah. So the question that Stephanie's asking is, do the various proteins, those 4 proteins I mentioned, do they co-localize? Do they form cross-seeded fibrils? I mean, there's a controversy in the field right now. I think that in general, they do not cross-seed. I think that basically individual proteins form their homomeric fibrils, but the presence of one can probably drive others to misbehave as well. Okay, I want to introduce you to the Michigan Alzheimer's Center, okay? Probably most of you have never even thought about it, but it's an important thing within our department and within this university. It's a center that really goes across university boundaries. So we really serve the entire state. It brings Michigan State on its 2 campuses, Wayne State and Detroit, and University of Michigan. Sadly now only the Ann Arbor campus, not our Flint campus, not elsewhere, together to really try to help understand and treat and educate and advance research in Alzheimer's disease. There's a major emphasis on understanding causes in underrepresented and underserved groups. Our theme is identify, understand, and modulate the many factors beyond amyloid that contribute to brain dysfunction and neurodegeneration and Alzheimer's and related dementias. This is what the field was like a couple years ago. Everyone was riding the amyloid wave. Everyone was studying amyloid. Amyloid is important, but it is not the end all of disease. And so we're really looking at things beyond amyloid. We have cores that do various things within the center. I'm fortunate to have Bruno Giordani as my associate director, and we have a clinical core headed by Ben Hamstead and Judy Heidebrink, a neuropath core headed by Andy Lieberman with Sammy Barmada's assistance, our data management statistical core headed by Kelly Bukulski in School of Public Health. Our biomarker core is actually based in Michigan State, and Nick Kanan and Dave Morgan and Irving Vega play a key role in that. Our neuroimaging core is at the University of Michigan, and Doug Knoll and Ben Hamstead run that. Our outreach and recruitment engagement core goes across the 3 universities and involves a number of scientists, Scott Roberts, Annalise Roman-Filipiak, Courtney Polenik, and others. There's a research education component that's important that helps to facilitate the education of younger investigators. We have an automated microscopy core within the neuropath core run by Sammy Barmada that facilitates research and particularly in non-amyloid neurodegenerative diseases. We have a new Latino satellite based in Grand Rapids. The Latino population has been understudied, and we're really working on that now. And I'm delighted to say both of them in the room here. Roger Albin has been the University of Michigan rec leader, and now Catherine Kazarowski. We're so lucky to have Catherine join us at the University of Michigan, is taking on the role as the rec leader at the University of Michigan. There also is Irving Vega at Michigan State, and Anna Doherty and Peter Lichtenberg at Wayne State. One of the things we do is we collect research participants, whether they are cognitively normal or have dementia or somewhere in between. We deeply phenotype them neuropsychologically, imaging, biomarker, and we give all that data to the national network, the NAC. Our enrollment is 31% Black African American, which is among the very highest across the entire country. We've made it a higher focus for us. And in fact, our work with Wayne State and our work in Detroit is key to that. We also have a mindset registry of many more subjects than the 700 deeply phenotyped that supports many other studies. We do a lot of work nationally with various groups, multi-center studies. I'm just highlighting a couple of them. One is the All-FTD, looking at the longitudinal changes in FTD and the genetics of FTD, with Sammy Barmada and Tanif Popley taking lead roles. Diverse VCIT is looking at vascular cognitive impairment, and we're leading that study in bringing in Black research participants to understand the vascular basis. Amanda Maher leads a super aging project. These are individuals who are like over age 85 and doing incredibly well. What makes them do so well? And the CLEAR AD study is a peripheral biomarker study based in Florida that we are one of the sites on. Those are just 4 of many projects we do. These are some of the major things we focus on, factors that contribute to cognitive impairment, particularly in underrepresented groups, developing non-pharmacological, non-invasive approaches to treatment, identify and disclose disease risk and research results, and define mechanisms underlying ADRD proteinopathies. Let me start with the first one here. We all know that dementia is common in all populations, but there's a disproportionate incidence and prevalence of Alzheimer's in Black people. And there's lots of reasons for this: health inequities, access to care, various causes that underlie this. And we felt that it was important for us to spend time on this very important gap in the field. If you look at the map of Michigan, it's a perfect, if you will, microcosm of the country in terms of economic deprivation versus economic wealth. And as shown here, individuals in the darkest red are ones who are relatively disadvantaged. This is from the Neighborhood Atlas, which is a wonderful study headed up by Amy Kind. Those with dark blue are basically the ones who have the highest economic and are advantage status. And you can see that we have here a half of a donut of blue surrounding a red center, which is Detroit. And we have lots of areas in our state, both urban and rural, that are basically disadvantaged. So our center is trying to hit the entire state. Of course, the population density in our state, you can see in dark blue over here. We have 4 sites for the center. We have 3 sites where we actually evaluate research participants. One is in Detroit, one is in Ann Arbor, and one is in Grand Rapids. This is simply where Michigan State and East Lansing is. We don't actually see research participants there. This is a lot of work, and we're real committed to this, and we are going to continue to try to make a difference in this area. So one of the things that I think it needs to be looked at more carefully is non-pharmacological approaches to cognitive function. And Ben Hampstead, our core leader, who's a neuropsychologist, has developed non-pharmacological approaches to treatment. This is Ben. Ben will become the associate director of the center, as will Sammy Barmada. I can't do this forever. He has a program here that's basically looking at basically transcranial direct current stimulation, or TDCS, where you actually put electric field over part of the brain, you enhance the circuitry, you can actually show changes in cognitive function. And I'm not going to go through all the details of his studies here. I just want to emphasize that he has studies that have shown that you could improve language and brain connectivity in those with logopenic primary progressive aphasia, and social cognition and brain activation in behavioral variant FTD, eye tracking and brain connectivity in PCA. These are all basically in the non-amyloid space, and the way you can use TDCS to actually try to activate things. And importantly, the effect of this varies depending on whether someone has a lot of amyloid or tau in their brain. So his R01 is to study the efficacy of TDCS in the presence or absence of amyloid and tau. Research 30 years ago was done in a sort of a paternalistic way. You would bring research participants in, you would collect data, you would never tell them squat about what was going on, and then you'd publish papers on it. It's not an effective model, it's not fair. We believe in a community-based participatory research where we give back to our research participants. That is a win-win in so many ways. Annalise Roman Filipiak in our Outreach and Recruitment Corps, a neuropsychologist. We have a lot of neuropsychologists who work as part of our center, has really led our program with Scott Roberts in giving back information to our research participants. And so these are some of the various things we've made is we develop standard scripts and training materials. We get feedback from individuals. We give feedback to people, and then we study how we get feedback on how the feedback goes, because we really want to know, does this make a difference? And so we've actually created a lot of different programs in terms of giving back information and seeing how people respond to that. It's been so successful that we've actually been asked by other centers around the country to be the leads in trying to help them do this as well. And so I won't go through this in details, but we have found that people really like this. We've done over 511 feedback sessions in the past year in 2023. And the rate of belief that this is helpful to those individuals is high. This has become something that's done nationally. We have to, as an Alzheimer's center, all the centers now have to get amyloid and tau imaging on a subset of individuals. We want to give that information back to our research participants. Annalise has been asked to be a leader in trying to help other centers figure out how to do that in a very important way. So one of the calling cards for a center that I'm really proud of. And finally, this is near and dear to my heart because I really am a mechanistic guy. I'm interested in how genes and proteins misbehave. And we have a lot of interest in the frontotemporal dementia space. You all know that ALS and FTD are a spectrum of disorders. Fascinating how certain genes like C9orf72 can cause ALS in one family, FTD in another family, and even in the same family can cause FTD in one individual and ALS in another individual. We don't understand that, but it's fascinating. There are a couple of these genes that people at the University of Michigan focus on. They include TDP43, C9 repeat expansion, and C9 FTD ALS. Tau, postdoc in my laboratory, Mercy Best, is actually down in Detroit today talking to our Detroit Advisory Council, who gives us guidance on how we enroll Black participants. She's working on tau, as are others. And in my laboratory and Dr. Lisa Sharkey's laboratory, we're looking at some of these proteins, including ubiquitin-2. No time for data here, sadly, but I just wanted to highlight a couple papers. Sami Barmada, you probably know this. Sami Barmada is a neurologist who is a world leader in TDP43 biology and its mechanisms of disease. I'm highlighting in yellow 3 of his papers. One of them is a preprint, and the other two are preprints, and one came out Molecular Cell last year. I have the privilege of working with Dr. Lisa Sharkey, who works on ubiquitin-2, which is a fascinating protein involved in ubiquitin-dependent pathways. It itself can cause ALS or FTD and accumulates in various neurodegenerative disorders. I'm just highlighting 2 of the papers that we together have worked on with ubiquitin-2. And Kelly Bukulski, who runs our data core from the School of Public Health, is a leader in studying the exposome, looking at, and I know Eva works with Kelly, she studies how environmental toxicants contribute to Alzheimer's and other disorders. So I'm just highlighting 2 of her papers here. The university gives out these mid-career achievement awards every couple of years. They give out 5 across the entire university. Sami won it 3 years ago. Kelly won it last year. That is a huge success for this. It shows you how good the work is that they are doing. And Lisa won a Lefkowsky Award last year. So all 3 of the scientists I mentioned have done very well. So that's a quick whirlwind. When it comes to anti-amyloid therapies, the times they are changing. They're not for everyone. They have a lot of risks. I think it's important for you to think about the disease modifiable risk factors that are not anti-amyloid therapies, because they're so important. Precision diagnosis, I think there are sensitive new blood tests. We're using them in the cognitive disorders clinic. I won't be surprised if they're used in geriatric clinics before long. They're not really being used extensively at this point in time. Moving beyond plaques and tangles, didn't have time to talk about this, but it is not just neurons. I think that the immunological landscape, the inflammatory landscape in Alzheimer's disease, it still needs to be tapped. It's one of the hottest areas in the field, but we don't have the therapies yet that target them. But I'm hopeful the next 5-10 years, we're going to see some immune-mediated targeting that's very helpful. And by the way, ApoE itself is a therapeutic target, and Catherine has shown that quite nicely. And there are many people now looking at targeting ApoE as a cause. And again, multipathology is the rule, not the exception when you think about dementias. And finally, we're here. We're doing science. We're doing clinical research. We're doing education. If you have an interest in participating in the Alzheimer's Disease Research Center, come join us. The center is big. This is a picture taken at our Community Appreciation Conference at the Eastern Mark in Detroit last year. Those are many of the staff and a few of the faculty. I'm not talking about my lab work, but we played hooky last Wednesday. We didn't go to Grand Rounds. We went kayaking instead. So here we are kayaking on the river. I think the University of Michigan in neurology is really extraordinary. And one of the things I love about working here is the number of neurodegenerative faculty who are here. And this is not everyone. I've left out some people. I'm sorry about that. But the ones in yellow are individuals who actually participate in some way with the cognitive disorders clinic or elements about the neurodegenerative space. And I'm going to stop here by saying that that's my mom. She's 93. She's a good case of a super ager. She shows you the resilience. She's dying Easter eggs. And I started with good art, so I'm going to end with bad art. This was a gift given me at Easter, which was a Bob Ross paint by numbers, so I got my own painting in. I will stop there and I'll get rid of that slide. Any questions? Thanks. We do have time for questions. And I don't know if there are any on the chat space. Doug.
Yeah, this is a dynamite presentation. Thank you so much. My question is about you and Morgenstern. Have you looked specifically at his community with respect to presence of various kinds of dementia? It must be a drove of cases in there.
Thank you for the question, but I couldn't hear what you said. Can you repeat again? What particular?
Okay. I'm sorry. I'm curious to know about you, your studies, and Louis Morgenstern's specific population, which
Yeah.
is a group of
So,
Latino.
good question. Lewis and the basic study has been looking at a Hispanic population and looking at cognitive issues. Lewis and I have talked about working together, but we actually have not worked together. Our Alzheimer's Center and the basic studies have not been partnering in any way. It's something I would love to see us talk more about. We have worked together with Deb Levine and others to try to really look at vascular causes of disease and contributing to an understanding of the vascular basis of disease. It's a good question. Doug, you had a question?
Just with all the people around here who do outcomes research and cost effectiveness analysis, have you gotten involved at all in any studies of the cost effectiveness of the biomarkers and trying to use those in a screening way and things like that?
No, we have not done that. I think it'd be very important to do, and I'm sure centers are now doing that. In terms of cost effectiveness of the anti-amyloid therapies, Roger and others have studied that a bit, and it's a cautionary tale in terms of the amount of cost that would be involved in implementing anti-amyloid therapies broadly across the country when you think about risks. Brian, want to comment on that? Doug, your question is a really good one. You know, I come from a mechanistic science background. I still feel like I have imposter syndrome running an Alzheimer's center that I myself have not done outcomes research, but I would love to support scientists who want to look at this. We give out money to development projects, to pilot grants, to Kickstarter awards. And so if people are listening and are interested in doing outcomes research, we'd be happy to partner with them.
Got a couple questions on.
Yeah.
This is from the Kellogg Eye Center physician, so apologies for naivety. How well can neuropsychological testing without imaging or biomarker measurements distinguish AD from late-lands? Does late lands never progress into executive dysfunction? Is there no late lands variance like there is with AD, like posterior cortical atrophy?
Well, good question. It's early days in the studies of LANS. If you look at the population of individuals 80 and older, this is crude. 1/3 roughly LANS, 1/3 roughly Alzheimer's, and 1/3 roughly both. Okay, so the co-pathology of the TDP-43 accumulation in the medial temporal lobe with Alzheimer's disease, and occurs about 1/3 of those individuals. And so it's the individuals who have only the TDP-43 accumulation and exclusively medial temporal lobe involvement that would have a somewhat pure amnestic syndrome without a dysexecutive syndrome. I would say in general, neuropsychology is very important, but it's hard for neuropsychology to say it's definitely this pathology versus that pathology. We use it a lot to help us get a sense of cognitive strengths and weaknesses in individuals, and to help them understand where they are in the spectrum of disease. But in terms of being able to say in the end, it's vascular, or it's Alzheimer's, or it's FTD, it's pretty difficult with just neuropsychological testing. And I don't in any means try to throw any shade at neuropsych testing. It's very important. Maybe one more question. Oh, let's go to the question over here and then we'll come back. Yeah, exactly.
So given the new emphasis on therapy, do you think at this point there's a role for those busting patients in really general neurology or in the hospital and ER ordering any of these biomarkers of this, right?
I assume they can hear online his question? No. What Zach was asking about is there's a role for, sorry, what?
The med school has the 10.
Okay. Okay, we got to go apparently. Can't answer that question. No. It's a really good question. I think it's there. We got to be careful. We have to be careful about when we use these, how we use these. So thank you all.